All right. Our next presenter is Dr. Arie Zakaryan. He's a pediatric pain psychologist. Dr. Zakaryan is a psychologist with clinical specialization. There we go. 5th time's a charm. In pediatric psychology and pain management. He received his doctoral degree with a child clinical subspecialty from Loyola University, Chicago in Chicago, Illinois. He went on to conduct his pediatric psychology internship at Rush University Medical Center in Chicago, Illinois. Dr. Zakaryan completed his fellowship in pediatric psychology at Children's Hospital of Orange County in their co-occurring clinic with a focus on treating patients with co-occurring medical and mental health diagnoses, especially for youth diagnosed with cancer. He also is fluent in Spanish and Armenian and conducts assessment and intervention in Spanish. Dr. Zakaryan joined Phoenix Children's Hospital in 2017 and is a psychologist as part of the pain medicine program. Dr. Zakaryan, along with the PCH pain medicine physician, Dr. Paolo Genovese, and PCH physical therapist, Rochelle Cherry Holmes, helps run the new weekly rehabilitation and pain program for chronic pain adolescents in the Mercy Gilbert Clinic. Turn it over to you. Thank you.
Thank you very much for the introduction. All right, there we go. So I'm really excited and honored to be able to join you guys today here to talk about, and thank you for Amy and the Soft Bone Symposium for a lovely introduction, kind of talking about, as it suggests here in the title, psychological treatment of pain, and really trying to tap into the power of our brain and behaviors and emotions that we can really kind of use to help with our pain management. All right, so disclosures, no financial disclosures, and I like to also make sure to say that I'm not a physician, so I won't be giving any information on medicines. And another piece is that there are a lot of other non-pharmacological ways to help with pain management too. Physical therapy, occupational therapy, osteopathic manipulation treatment, acupuncture, and I don't have the time to talk about all those pieces either, but they are really important. Likewise, I might not be able to go in full depth with all the different strategies, so I will try to go through my kind of presentation, and then especially maybe during the Q&A or in the future if other questions come up, I can try to be answering them as best as I can. And like I think Sue was mentioning in our kind of reintroduction into the afternoon part of the symposium, I might not be able to answer specific, like, diagnostic or treatment-based questions or give therapy in this format, but I will try to answer the questions as best I can. So kind of looking at what we want to achieve for my presentation is talk about the prevalence, like how much pain or chronic pain is going on in patients with hypophosphatemia, HPP, or other bone-related disorders. Another caveat I'm putting in there is, as we can, I think, have been discussing through the day, there's growing research on HPP, especially thinking about in pediatrics or in adults and in general. So I've included some research studies or some work or reflection on patients with other kind of bone-related things like osteomalacia, rickets, or osteogenesis imperfecta, which is not, these are not the same things, but just trying to get things that are kind of in the close to it as best as I could for some research evidence. Likewise, I might kind of discuss some things about my little skew on pediatrics and or thinking about just pain populations. Talking about different theories about pain and pain models that are out there, and then kind of identify the different pain coping skills that people can use, and sometimes initially more broad strokes by age, and then get into the categories a little more specifically. Okay, so looking at kind of pain prevalence in HPP and other related bone disorders, one small European study looking at 52 adults had seen that 90.4% of those patients had reported pain as part of the different kind of symptoms that they were facing and dealing with. Looking at a more different kind of study, but another a small study that was looking at OI patients, they had a quarter of people reporting acute or like 3 months or less chronic type of pain, a quarter reporting chronic, like 3 months or more type of pains that they were facing, and then a tenth of them reporting both. And of course, or not unsurprisingly, the frequency of that chronic pain increased with age as for those patients in the study. Other considerations that we would want to think about are different structural lesions that could be going on for patients in the spine and joints, osteoarthritis in those areas, and also oral health or other kind of dental components that we would want to, perfect for Dr. Clark who just presented, right? Those are important things to consider. And one small European study looked at oral quality of life. And they had reported that the numbers were lower and it was like harder for psychological functioning for XLH, so not the exact same thing, the X-linked hypophosphatemia compared to the OI participants in that particular study. So then thinking about other comorbid concerns, so that's like thinking about co-occurring things that can come up for patients who have some of these bone-related type concerns. So this is looking at compared to the general population, kind of mostly like same age kind of people that the study is looking at. They were reporting lower quality of life for adults with XLH, also lower quality of life for kids and teens with OI. Different kind of studies looking at anxiety, distress, and low self-esteem being issues that some of these patients are facing. Again, not surprisingly, thinking about realizing and noticing feeling different, especially in different transition points, like from childhood to adolescence, from adolescence to adulthood. And some of these studies, again, they're small studies, but qualitative. So looking at kind of interviews and like kind of getting quotes of things, where these participants are sharing their first person perspective, saying things like, again, this study happened to be on OI, but like, it is not just a physical condition. Also, a lot of reflections and themes from these kind of qualitative studies looking at how frequent interruptions to school, to being able to pursue further education, some like work interruptions, medical appointments all the time, fractures or recoveries from big surgeries, all of these things interrupting their life, their quality of life, and being able to achieve what we are seeing as typical developmental trajectories. So those are kind of been difficult. And also for thinking of pediatric patients, affecting their parents' work and life as well in reports. But not only do we want to look at some of these difficulties, but also keep in mind that there was also mentions and reflections on the different strengths and resilience of these patients. And so that's another key thing that we have to make sure to note, and I like to note, is thinking about what are strengths and qualities that can be tapped into, whether at the patient level, the family level, or other level, community level, that can be garnered for better patient treatment success. Another thing that they mentioned in these studies I remembered is how patients and parents are experts, and so kind of making sure that we engage them with all their knowledge that they have and all of that kind of components that's important to consider too. Okay. So now kind of think about different theories of pain. Dr. Belther was kind of alluding to this a little bit during their conversation from the orthopedics, and it's kind of like this gate theory that is a somewhat more recent kind of idea when it comes to how we understand pain, and it's looking and thinking that pain perception and how we modulate pain can be affected by our neural gate through the spinal cord, and how this can be affected by psychological factors. And this is one of the first times that those kind of factors were incorporated into theorizing about pain management and perception. Ways that the gate, quote unquote, can be opened. It can be physical, so that's like physical medical, like having an injury, having an illness, having a diagnosis. Behaviorally, that's more like not getting good sleep, not eating right, not getting enough hydration, not moving, doing whatever is appropriate exercise for that particular patient. And then emotionally or psychologically, feeling sad, mad, stressed, or scared is going to make the pain gate open more and increase that pain. Then thinking about factors that can help close our nerve gate. At the physical level, the medical level, of course, taking medications or anesthesia. Behaviorally, not attending or focusing on the pain, talking about it as much. Instead, if we talk about functioning and what we can do, that can help close the gate a little bit, as well as, of course, eating right, drinking right, getting the right exercise, sleeping well. Sleep hygiene is a big thing that we'll comment on. And emotionally, feeling happy and relaxed and calm can, again, not magically make these disappear, but help kind of hopefully decrease how much is going on. At the onset, I also want to make sure to talk about, as we've been saying, that kind of integrative approach and this multidisciplinary approach is very important. And I'm very grateful that we have these kind of members up on the team for the majority here at Phoenix Children's. We, of course, have our physicians who are a big part of our team, our nurses and nurse practitioners, psychologists. We work with PT, especially directly in our intakes and with our team. Then we do a lot of referrals to occupational therapy, who are crucial, and different complementary and alternative medicines, like the acupuncture and osteopathic manipulation. We can also refer and patients can get help from child life specialists and social work and getting connected to resources, because that can be another barrier that is going on, in addition to just also therapy and other familial support too. So again, I'm not wanting to just briefly kind of touch on making sure physical activity is a big thing in, tailored appropriately for each and every patient, especially when we're considering HPP and other bone-related kind of disorders. And so PT, OT, aquatic therapy is a big one that we see, hopefully being able to work on in the water where it's warmer oftentimes, and it reduces that gravity, so they're reducing the pressure on your bones and joints. And again, appropriate patient-tailored, patient-specific exercise. So another kind of model, again, this is not like a kind of out there researched, everything has been, proven in that regard, but at least kind of anecdotally and also clinically, we see this as something that, while discussed with pediatrics, really can be applied to all ages. Being able to think about what is maybe an illness that is a big piece of it. What could be other triggering events or stressors that are going on? Family factors, which we'll get into in the next slide. Other psychological events, meaning thinking and thoughts. And then these other pieces that are really, how do we cope with it? How do we, maybe we're getting deconditioned. How do we deal with that? How do we deal with school issues? And so just other kind of components that really underscore the complexity of this all, but especially, at least in our clinic, a big part is going to be getting back to functioning and switching that. We're not only talking about pain scores, but our goal is a lot about functioning for our patients. Then thinking about parent and family factors, also very important to consider. So when we think about family level, so that's going to be thinking about, the family's functioning, thinking about the environment and the life cycle stage, whether that could be, are these older parents with their only or youngest child now at this point? Is this a family that maybe was dealing with different fertility concerns, and this is the product or the miracle of that fertility journey for these parents? Something to be important to just keep in mind. Then thinking about parent level variables. So, that kind of being, what are the emotional levels of the parents, or what medical history do they have, or what diagnoses do they have? And then with the child, developmentally, where are they at? Thinking about that, thinking about their perception and response to pain, and the physiology, biology, the behaviors, the emotional state that they're dealing with. Okay. Now kind of getting into the broad kind of age kind of brackets of thinking about what do we use for different ages of little kids and to adults. So when we think about infants and babies, a lot of research has been out there looking at breastfeeding and sucking, and how that's really important to consider, and hopefully can be advocated across the board when people are getting immunizations and even heel pokes or needle sticks, that can be as effective as a medication like a Tylenol or other things. Skin-to-skin contact with parents, caregivers, mothers, using the oral sucrose, so sugar, and having that has been shown to be as equal to Tylenol for helping infants and babies. And then even, again, positioning, to making sure to not restrict or restrain, but more about finding being in a parent's lap, being able to hold or touch. And that can be this kind of important other factor that can help out as well. Now, as we go on, kind of getting into children, of course, tried and true, distraction for sure is something that we can use. TV, video games, tablets, we've got a plethora, especially nowadays. And then relaxation, biofeedback, hypnosis, music, humor, touch, again, holding a child's hand, being able to have that is another component. Then all of these we can kind of add on, and when we think about kids and teens, other important considerations are going to be language and parental empathetic attention. So this kind of conciliatory kind of as it's saying here, really wanting to avoid, are you okay? Is everything okay? Oh, I'm so sorry I'm hurting you. Or I'm so sorry we have to do this. because what that is implying is that something damaging or something bad is happening when probably not. Probably it's something that just is required as a part of the medical piece. And that kind of reaction, the research has shown, can increase a child's pain perception in how they either recount in the moment, or sometimes some of the research looks even like in the future, 3 months down the line. So we don't want to pretend like, again, it's not the opposite, like suck it up, just deal with it. But we want to validate and kind of praise what is going well in the moment, but not lie or give that too much attention to the pain. You know, we're not going to tell someone who's flailing about like, you're doing great, don't worry. Because then that is where kids and teens start to mistrust their parents and adult authority figures or nurses or doctors, and it can make children who have difficulties with procedures to become like needle phobic adults, like 25% or so out there. And so we want to kind of be able to change how kids and teens who now are more socially aware, and they pick up on cues and they know what's kind of going on even if they can't say it, and we want to be careful about that. Another piece is encouraging self-efficacy, and that's just like our ability, you know, our own ability to handle many different things, but in this case, pain management. So we want to really kind of notice that in our pain populations. Then everything that we talked about kind of progresses on to teens and to adults and older adults, all the ones from before. And of course, with our cognitive development, we can depend a little bit more, and I didn't put it in this exact list, but we'll get into cognitive behavioral therapy, thinking about hypnosis and mindfulness, meditation, and those things, yes, can be a little bit easier for adults, but can be tailored to kids and teens as well. So now kind of delving in a little deeper with each of the categories. So noticing with behavioral relaxation, first up, distraction. Again, we know that it works from our personal experiences as well as the research shows it too. So even interactive and passive distraction. So interactive in this study was like using a joystick to play a video game, and then passive was just watching the video game. And both were equally as helpful to help during with pain reports on a procedure. Then even like looking at cartoons can be helpful, where patients after a 3-minute cartoon were able to report lower pain scores during that procedure and lower cortisol and glucose levels, which would suggest a lower stress response. Because that's another key thing that's happening is our fight, flight, freeze response. Our sympathetic nervous system is getting activated, and that's where our pain gate can also become opened, our nerve gate. And so we're kind of tackling it from all of these different levels. So we want to kind of think about that. Timing is also important. What the research shows is that we can't do things after, we can't do the distraction after the event, we have to do it during the event, right? And this study showed that, you know, giving stickers afterwards did not reduce the pain scores. But a little side note that we're going to come back to is that giving praise and giving something as a plan, as a positive reinforcement plan for what you've done, what the child has done well during the procedure, that will reinforce the good pain coping skills. So that's a little bit later, but if we're trying to just pure distraction, we want to do it during. Okay. Then, good old diaphragmatic breathing. As you know, redundant as it might sound, or like a broken record, it's there because the research shows that it can work. And again, maybe not every time, maybe not every situation, but one of our tried and true ways of helping to change our fight, flight, freeze response to our rest and digest response, from our sympathetic to our parasympathetic nervous system. And there's a ton of different versions out there, and more about, it's like finding the one that works for you and or for your child or whoever we're working with. It's often combined and subsumed in the behavioral part of cognitive behavioral therapy, as well as one of the mechanisms to help us become in the present moment, to help us with our kind of mindfulness, meditation, hypnosis, and yoga techniques as well. And they also use it a lot in PT too, so it can be really helpful across the board. Then the next kind of behavioral kind of strategy, again, it's going to really depend, patient-specific, tailored, you know, just depending, is progressive muscle relaxation, if it's appropriate, if it's even possible. And the general idea for this is like tightening muscles for 5 to 10 seconds, then loosening them for 10 to 20 seconds, and usually kind of repeating that, going through different muscle groups. The kind of helpful component to this, one of the additional pieces, is kind of bringing this awareness again to our body and to our muscles, and this kind of attention on purpose to how they feel when they're tense and how they feel where they're relaxed, and how you are kind of in charge of that. And so that on purpose thing is something I'm a little more biased to. So my little sayings that I go is not about practice to make perfect, because that's kind of not possible. So it's not really a great thing to focus on. But instead it's the 3 Ps: practice on purpose to make permanent. Because it matters more if we do things purposely to kind of turn on our attention and our awareness to then learn, and then we get to keep these strategies kind of forever as a good habit to help not only with pain coping, but anxiety, nausea, sleep, mood. And so that's why it can be really helpful across the board. Then biofeedback is another kind of behavioral piece. This one is kind of like where clinicians can monitor a physical function for the patient, and it builds up that awareness of your body. It can be on breathing, heart rate variability, galvanic skin response, just like sweat kind of on our palms or our fingertips, and EEG, the kind of electroencephalography, so like wearing that cap with the little electrodes. They've seen that it helps with migraines and tension headaches and recurrent abdominal pain. And the nice part is it can give immediate feedback, which some of our other starters don't really do. And it's non-invasive, and there's not going to be really side effects compared to like medications that often do have it. We just want patients and families to be careful, to be what kind of clinicians they go to, what kind of trainings have they had, are they being exorbitant or really expensive or not, or so just being mindful of it. But there is like growing research that's looking into it. Yes, sleep hygiene, one of the very difficult things that so many people deal with. And so what we think about, again, we try to, at least I, we're going to try to tailor it for each patient and each person to make it in a slow, steady kind of way to try to work on it if it's needed. We are basically trying to help regulate and help bring back into kind of a pattern our circadian rhythms, that kind of 24-hour, 25-hour rhythm of the body, where when it's dark and late, we sleep. When it's getting lighter and our melatonin levels are getting lower, we are awake and alert. And then it's dark and melatonin increases in our body naturally, then we get sleepy and we go to bed. We want to kind of get back into that rhythm. Basically also, when it comes to our psychological strategies, we want to behaviorally train the body to connect the bed only to sleep. We don't want to be eating in our bed, doing homework in our bed, playing video games or watching TV, especially if our sleep is disrupted. And if we're tossing and turning for hours, at night, we want to get out of our bed and do something boring and relaxing, and then come back when we're tired to try to, again, only connect the bed with sleep and not being alert and awake. Because we know, anecdotally and also in the research, not only are we going to be more sensitive when we wake up that morning, grumpy, tired, more stressed, but also our pain sensitivity goes up. So we want to try to tackle that as well. Then now kind of bumping into the more cognitive strategies. One of the big family of strategies that I like to consider is thinking about imagery. And so this can have a lot of overlap with a lot of different things. So it can be ranging from guided imagery, visualization, mindfulness, meditation, hypnosis. And they all are going to have different backgrounds, different trainings, and sometimes certificates, different belief systems that are behind them. And so it's being mindful about that. Basically, a lot of the big things is trying to engage our 5 senses as much as possible, whether it is like in the moment actually or visualizing and imagining them. So what we've seen is that another kind of common thing is people are going to be encouraged to imagine a favorite place, a positive place, or a place where they would feel relaxed, safe, secure, or capable. Some of the, again, my bias of pediatric research, but looking at sickle cell pain for pediatric patients using guided imagery, they reported increased self-efficacy, that ability to handle their pain management, a decrease in pain intensity, and less pain medicine or analgesic, pain relieving medicine use. With the perioperative pain, so like during, after, before pain, the people who used guided imagery reported less levels of anxiety, less pain, and it was statistically significant, as researchers like to look at, for the experimental group. So the ones who had guided imagery versus the ones who were the control group, who just did kind of the standard care that their hospital was giving them. So now kind of another one, kind of family of this, is mindfulness. And so that first quote is kind of by Jon Kabat-Zinn, the father of modern kind of mindfulness. And but it's a good definition where we're going to pay attention in a particular way on purpose in the present moment, non-judgmentally. So it sounds simple, but it's a lot of components there that are really hard to do and live out. So the mindfulness-based interventions try to look on different kind of exercises that relate to breathing, meditation, and movement. It's really trying to kind of cultivate and develop this kind of awareness of being in the present and being compassionate and gentle with ourselves in that kind of strategies. So for peds, they found people who were able to kind of have more improved functioning scores, and they were able to decrease their disability scores and increase their decrease their frequency of pain complaints. And for teens, they also reported improvements in depression symptoms and improved ability to accept their pain rather than trying to control it. One of the meta-analyses, so that just means like a study that looks at a bunch of studies combined together on mindfulness ones, found changes, I won't go into it so specifically, but changes in the brain. So they took those, imaging pictures, the functional magnetic resonance imaging, fMRIs, before and after, and they were seeing changes. So if we can get some kind of changes into the brain by just doing mindfulness, like sitting and doing it an hour a week or whatever it might be, and dividing it up maybe a little bit each day, that's encouraging things that we want to try to work on and tap into. Then another kind of piece is the clinical hypnosis, kind of hypnotherapy. And so what that basically is going to be is like being in a state of really focused attention, where the patient would be more open and responsive to suggestions that are targeted for them and helpful for them and based on their goals. So of course, for my patients, it's going to be on pain relief, but this can be used for a lot of clinical applications: sleep, smoking cessation, weight loss, trauma, enuresis, like peeing at nighttime, when we're not supposed to be. And so these can be applied in a lot of different ways. What it is not, we're not talking about magic or mind control or being asleep or unconscious. Unfortunately, media and like TVs and movies kind of like give this bad rap. And that is stage hypnosis. That's like for a show. And that's not what we're going to use in the medical field or like for people who are appropriately trained. You want to make sure people are trained, but for those who have the right training, they're going to be doing it to help us and to help you to be able to handle things better. But it's just like any other thing. It's another tool in the toolbox. Some people benefit from Tylenol, other people from ibuprofen, some people from guided imagery, other people from clinical hypnosis. There's no right or wrong. We just want to do it in a safe and like licensed kind of way. Some of the common elements: focusing on pain relief, having this controlled dissociation, so kind of being able to kind of step back from the immediate environment, as well as kind of time distortion, being able to kind of differentiate between the here and now, the here and there, the now and then, whether that's the past or the future. It's kind of like a more targeted or purposeful way of daydreaming, where we're kind of in the car and we start off at home and then suddenly we're at work and we're like, how did I get here? And it's like doing that more in a purposeful way and a targeted way. Then another burgeoning area is virtual reality. And so how are we able to do this more now is that technology has become more advanced and it's cheaper than it used to be. So we can kind of tap into it. For now, it kind of is like almost a more immersive, distractive kind of strategy. But the good news, I think, with more time, more understanding, more programs, we can maybe make it more like a guided imagery, more like a long-term kind of ability to tap into for our patients. And here, even at Phoenix Children's, we have different research studies for the children that are having different procedures using virtual reality. Now, kind of getting, again, more into the cognitive behavioral therapy. So when we're looking at this, we are wanting to understand better how our different things like are possibly distorted and sometimes true, but oftentimes kind of affected thoughts or behaviors or unhelpful emotions that can be exacerbating our pain or getting in the way of our coping skills. So how can we be kind of bringing our awareness and understanding to them? Because we know that in conjunction with learning and behavior, our cognitions, our thoughts, how we attribute things and reasons, our beliefs can really be either enhancing or interfering with our pain coping. So we want to make sure we understand that in this model, that environmental events don't just directly impact us, they are also going to be filtered through our mental understanding, And so we want to kind of notice what's happening and how we can change the things that could be like challenge and reframe, restructure distorted thoughts or unhelpful thoughts and behaviors, which I call thinking traps. And these negative automatic thoughts are we'll call them cognitive distortions, and change them to more positive self-talk. I like to make sure I tell my patients and everyone that that doesn't mean like, sugarcoating or be like, don't worry about it, it's no big deal, it's going to be fine. Because that's not real, right? That is not authentic. We have to think about it realistically positive, or like in a realistic, optimistic way, to acknowledge the difficulties and how can we kind of be adding hope into the mix. So this also is going to hopefully help increase that mastery, that self-efficacy as well, that is just, we see as crucial in our pain coping skills. Another interesting thing is that we kind of continue this even when we leave the psychologist or therapist, the counselor's office. Because even by attending PT and OT visits, we can help people and patients can help challenge the catastrophizing or that kind of snowball thoughts, mountain out of molehill, unhelpful thoughts. And we can kind of, by just seeing like, yeah, I can do this. Maybe it's 1 minute at first. Maybe it's going to be like, I can do this for like 2 minutes later and then 3 minutes. So we're able to fight back against the I won't, I can't, I'll never. And that's a way that we can do it and build that self-efficacy. Does it mean that, can we say that you're doing CBT at those things? Not exactly, but it just helps kind of flesh out the model, which is nice. Then acceptance and commitment therapy, ACT, is kind of like a third wave CBT. So it's just an extension, and its big kind of goal is going to be to, as it says here, like create this rich, meaningful life, again, full of vitality. That's another big kind of thing that they think about, while accepting pain that kind of, and distress and discomfort that inevitably comes with our life. Now this, another important factor is that this is not an acceptance as in like, I don't care, or like resignation or something like that. This is like an active acceptance and like an active engagement with psychological flexibility, being flexible, pivoting, and actively doing actions that live out your values. And that's like that's like what it's more about. It's not just like sitting around being passive, it's being this kind of psychological flexibility. The other kind of differences that we just came from CBT with ACT, we are not focusing on the cognitions or the content of the thoughts or the sensation, like the pain intensity per se. We are going to be thinking about how can we build up the repertoire of our reactions to these things, and how can we be becoming more flexible so that we can go between those different reactions, so that we are again choosing the more positive and like value-based action that we want. Right. And then the other piece, another big one, is non-judgmental, and again, similar to mindfulness, surprise, surprise, and we incorporate a lot of mindfulness in ACT. And that in pediatric cases with pain, it was also important for psychological flexibility for the caregivers. And that when they were able to engage in that way, the children and teens reported lower levels of pain scores and stuff. And this is just to kind of, again, I'm not going to go over everything, but just seeing like very common things that come with ACT is this six-sided hexaflex, they call it, or the middle one is the more kind of condensed version of the triflex. But just kind of looking at, different behavior change processes, being able to pay attention to the now, making sure we identify our values and what are our committed actions to that. And when there's disconnect, that's where we get a lot of inflexibility and like more kind of difficulties. And acceptance, again, not just like passive, but accepting what's happening in the moment, as in like, I'm experiencing this, but it's just a feeling. This thought came into my mind, but it's just a thought. It'll change to a different thought. Diffusing from our thoughts, so not getting like stuck with our thoughts and just thinking them as complete truths, and then being able to take perspective. Then another big piece is going to be the family, right? Because HPP and then any other chronic illness really, but it's going to affect the entire family. Pain affects the entire family, right? And then how one interacts in the family is going to influence your pain. So we want to just be kind of mindful about all of that. And so we do this a lot in pediatric psychology is just like, we're working with parents a lot and with the children and teens. But what we want to do is that we in pain psychology are going to do more than just work on individual coping skills or individual relaxation and cognitive skills. It's going to be trying to engage in different parenting or family kind of aspects too. So, like we were talking about, the little hints from before, the positive reinforcement behavioral plans to promote that self-efficacy, whether that's like for your pain coping skills, for your PT exercises at home, for regular homework and other chores, working out to kind of be able to build that up so that, again, patients can be feeling that sense of aversion of control. Because when we have a chronic illness, that was kind of out of our control. And then thus our fight, flight, freeze response is almost always on, or we're always like experiencing, especially if you have chronic pain, that's a chronic stress every day. So that's always kind of being engaged. And we want to make sure we're helping to regulate it, and having a little bit of control through your efficacy and a schedule or structure or positive reinforcement plan can really help with that. Then another kind of piece is going to be thinking about, how we were mentioning before, paying a lot of attention to the pain, or kind of doing too much care and kind of rescuing, in this case especially kids and teens, but could be anybody. That is a natural parent instinct, right? It is what we want to do. If there's pain or if there's trouble, save and like help our children feel good and not feel bad. But what that can do is kind of not promote as much self-efficacy, which is the tricky part. And then it's not developing that appropriate levels of independence. But we don't want the opposite side. We don't want patients to feel invalidated, or to say, like, again, like, just suck it up, or at least you're not living in this, like, very poor war-torn country, or like things like that, that is not, sometimes is meant to make ourselves feel better in comparison, but it's not very validating. And then that can make it seem like I can't talk about these difficult things because we are just going to push them away. So we want to find a good balance between those. And we also want to notice what is the role that that person with HPP or whatever kind of illness might be is playing in the family. Is it a kind of sick patient role, or is it something else that can be engaged with? So again, it's usually, these things are not purposeful or malicious. It's usually inadvertent, but if we can kind of get an awareness of it through counseling and therapy, perhaps often, but even in general, that can be sometimes ways that we can help identify these dynamics that can exacerbate our pain and get in the way of our coping. And so when we change them, we can cope better with it, and like all the things that we're doing can have a more kind of efficient, efficacious effect. And last but not least, what I like to make sure I say is that it's, whether you're a caregiver caring for a child or teen with HPP, or an adult with HPP with family members who are also their siblings or other kind of like spouses and partners, that is taxing and exhausting and difficult, that it can increase, mood and stress and other kind of anxiety issues. So it's okay to get help for yourself as well, because by getting help for yourself, especially in, again, my bias of working with children and teens, the only way you can be the best parent is to also get help for yourself, so you can be there with the right resources and enough of that emotional energy and ability to take care of your child. So that's another thing that hopefully can help decrease that stigma, that we want to make sure we're also taking care of ourselves so that we can help those others around us as well. All right, and then a quick thank you to pediatric pain psychologist Dr. Mark Copenhagen, who was one of my mentors and helped with the slides for this presentation.